Good morning, everybody, and welcome to Module 7 of 20 Happy. This means we're 2/3 of the way home with our last 3 modules, and we thank you for being one of more than 1,700 ophthalmologists that have registered so far. All the technologies we've discussed so far have been, of course, IOLs. So we're devoting this module to non-IOL technologies that can either complement or augment a premium IOL practice. We've had more than 80 international faculty who've done a terrific job, and today will be no exception. And our moderators will be Mitch Weichert and Rob Weinstock. One of the best features is that we devote plenty of time for questions at the end. So remember, you'll be able to log into one of 3 rooms where we divide our faculty to ask any of the questions that you have. And then at 1:15 Eastern, you'll need a separate link to get to the non-CME program. Today, it's sponsored by Ocular Therapeutics, unique technology for patients, physicians, and facilities. And this will complement one of the topics, which is new drug delivery, very nicely. And the faculty are Terry Kim, Alice Epitropoulos, Nicole Fram, and John Hoganessian. In addition to Ocular Therapeutics, we also want to thank our other sponsors, Alcon and Zeiss, Allergan, Bausch, J&J, Lenzar, Novartis, RxSight, Star, Tracy, Centricity Vision, iPoint, LensGen, Sun, and Rendia. We have unrestricted educational grants from Alcon, Allergan, Centricity, J&J, RxSight, and Omeris. If you haven't yet, there's a special section on the website where you can, each of the sponsors has the ability to put up links to some of the products that are discussed, and that's particularly relevant today. It sort of forms a virtual exhibition floor for us. And so with that, I'm going to turn it over to Mitch to introduce our first 2 speakers.
Thanks, David. Very excited to get started. Our first 2 speakers will be Zaina Almataseb, who will talk about what's new in biometry, and she'll be followed by Laura Perryman, who will discuss technologies for ocular surface diagnosis and treatment.
My name is Zaina Almataseb, and I'll be discussing aids in biometry. I am a consultant to Alcon and Zeiss. Historically, different machines measured different parameters of the optical systems for biometry, such as axial length, corneal power, and anterior chamber depth. Emergent ultrasound was used to measure axial length, and errors occurred especially in the presence of staphylomas. Manual keratometry is very operator dependent. Modern optical biometers, on the other hand, combine multiple technologies into one device to capture all these variables. The tried and true standard biometers like the Hog-Streit Lenstar and the Zeiss IOL Master 500 use automated reflectance keratometry for anterior corneal measurements and optical low coherence reflectometry and partial coherence interferometry for axial length measurement. Neither measure the posterior cornea. In this presentation, I will discuss the new biometers, the IOL Master 700 by Carl Zeiss, the Argos by Movu and Alcon, the Galilei G6 by Zemer Ophthalmic Systems, and the Pentacam by Oculus, the Anterion by Heidelberg Engineering, and the iStar by Hog-Streit. Many of these biometers employ swept source optical coherence tomography technology, which provides multiple advantages over older optical technologies. The OCT takes more measurements per given amount of time and provides higher anatomic resolution and lower within subject standard deviation for axial length and anterior chamber depth. The greatest benefit is its improved penetration through dense cataracts. The IOL Master 700, Argos, Anterion, and iStar utilize swept source OCT. The last 2 still aren't available in the US. Many studies show a higher successful measurement rate when using the Argos or IOL Master 700 when compared to the Lenstar or the IOL Master 500. The IOL Master 700 utilizes swept source OCT to image structures in the entire length of the eye and generates a full high-resolution B scan. It has excellent penetration and repeatability, and the device allows for a visualization of 1 millimeter of the foveal pit. This not only helps with verifying fixation, It's also a potential screening tool for macular pathology. In addition, it combines cellocentric keratometry and swept source OCT technology to determine posterior corneal surface and total keratometry. This was shown to result in better refractive outcomes compared to conventional keratometry in toric and post-refractive eyes. The newest software update shows central topography, which provides anterior and total axial maps to help detect clinically relevant corneal irregularities. Typically, biometers calculate axial length using a grouped index of refraction for the entire eye. Segmental axial length, on the other hand, is when the axial length is calculated by summing the individual optical path lengths while considering their respective refractive indices. Doug Lee and Mitch's study show that in extremes of axial length, use of the segmental axial length might be more accurate. They found less myopic results in short eyes and vice versa in long eyes. This is promising, but more research is needed in this area. Alcon has partnered up with MOVU to develop the Argos biometer, which utilizes a segmented axial length. This is an excellent technology with quick measurements and the benefits of utilization of swept source OCT. It's able to penetrate dense and PSC cataracts, and it utilizes reflectance keratometry and swept source OCT to capture anterior corneal measurements, but does not measure posterior cornea. Two biometers that add tomography for corneal measurements rather than reflectance keratometry are the Pentacam, which has one Scheimpflug camera, and the Galilei, which has placido ring topography and two Scheimpflug cameras that compensate for decentration. Both biometers use spectral domain OCT and not swept source OCT. The benefit of utilizing Scheimpflug technology is that they both measure the posterior cornea and allow for calculation of the total cornea. This may be helpful in improving outcomes in abnormal eyes, such as patients with a history of corneal refractive surgery or keratoconus. The Anterion biometer, which is still not FDA approved or available in the US, utilizes swept source OCT technology for all its measurements, including the posterior cornea. It will be interesting when it becomes available to evaluate its accuracy, since the K measurements all rely on elevation data and without placido or reflectance technology. The iStar 900 is also not yet available in the US or even released by Hogstrite. From the website, it appears that the iStar will utilize swept source OCT and provide the user with excellent measurements, topography maps, and cross-sectional eye images. Many studies show increasing accuracies with these new devices. This particular study shows excellent agreement between the Argos and the Pentacam. This study shows excellent inter-observer repeatability with the IOL Master 700 and Argos biometer with excellent agreement. This one shows good agreement and repeatability between the Argos and IOL Master 700, but a statistically significant difference between measurements. And this one compares the Galilei with the Pentacam and found that although most measurements were statistically significantly different, there was still good repeatability. This compares keratometry measurements of the IOL Master 700 and the Galilei, and although the cornea indices were highly correlated, measurements were not interchangeable. And this one compared the IOL Master 700 with the Anterion, and although there were small differences between the two devices, there was still good agreement. In summary, over the last decade, there have been significant advancements in biometry, specifically in measuring axial length and keratometry, especially in abnormal eyes. These new devices have increased capture success rates and increased repeatability. In addition, there have been a push by newer optical biometers to combine multiple technologies into one device to capture all the variables. Because of the differences in technologies to measure these parameters, even though there is good agreement between them, these devices aren't necessarily interchangeable, and more research is needed in this field. Thank you.
Hi, Laura Perryman from Seattle, Washington here. Pleased to be here talking to you about dry eye diagnostics and treatments. Here are my financial disclosures. I just wanted to break it down into three easy sections: the diagnostics, the procedures, and the devices that we have. Let's talk first about the diagnosis. I think it's important to remember the TFOS-2's two definition for dry eye disease and point out that there's a loss of homeostasis, hyperosmolarity, inflammation, and neurosensory abnormalities in the definition of dry eye disease. We have neural stimulation to address those neurosensory abnormalities. Brand new device approved this year, showing improvements in staining, Schirmer's, tear breakup time, symptoms, as well as meibomian glands yielding liquid secretions and meibomian gland secretion scores with a simple external device. With the dry eye workup, it's really only comes down to 4 simple steps. Ask the questions with your standardized diagnostic questionnaires, assess your risk factors, do your testing, osmolarity, MMP9, meibomography, and then categorize your treatments based on what you find. And we're kind of doing these things anyway in the cataract preoperative workup. Vision's important. Osmolarity, we know that there's keratometric errors with hyperosmolarity, so we have to check for it and address it preoperatively. MMP9 can have an impact on our patients as well. Go ahead and look at meibomography because we know blepharitis gets worse after cataract surgery. The Ascaris algorithm teaches us to look, lift, and push-pull, and it's looking for comorbidities such as floppy eyelid syndrome and rosacea. Here's her meibomography. Significant constipation of those glands, drop out as well. Dry eye starts early. Don't forget about that. 21-year-old who wanted LASIK, significant lid seal insufficiency, and a concerning amount of meibomian gland atrophy in this patient. Because really what we're trying to do is prevent the 20/20 unhappy patient. Here's somebody who had had LASIK, had had cataract surgery, and isn't seeing all that great. He's not very happy. He has rosacea and MGD, and floppy eyelid did not get diagnosed preoperatively. The bottom topography shows his topography before we started treatment, and the top topography is just 2 weeks later, and he's doing much better. He's a little happier. When we talk about dry eye disease treatment approaches, we are aiming everything at inflammation. Inflammation is at the epicenter. And the reason for that is it drives other inflammation. So in a healthy system, you're able to return to homeostasis, right? That's part of the definition of loss of homeostasis. But with dry eye disease, you lose those immunoregulatory mechanisms and you're in chronic wound healing overdrive, this chronic vicious circle of initiation, amplification, recruitment of T cells, damage and self-perpetuation. And where you see asterisks is where there's a role for the medications you have in your toolkit. Where you see a star, there's peer-reviewed literature showing it's the role of IPL in addressing those inflammatory markers. Ultrastructurally, dry eye disease creates abnormalities too. Here is confocal microscopy showing an abnormal subbasal plexus, abnormal epithelial cell density, and keratinocyte hyperreflectivity or high activation. You don't want to go doing PRK on that, increased risk of haze. After 6 months of therapy, you have a normalization of the subbasal plexus, 4-fold increase in the epithelial cell density, and a normalization of the keratinocytes. The dry eye is essentially on chronic wound healing overdrive, and we're about to cut into this and create an acute injury, acute wound healing response on top of it. Be careful of MMP9 because it's correlated with the development of neuropathic pain. Lifitegrast can have a positive impact in your refractive accuracy. Brand new paper, 100 patients, improvements in the IOL calculations, higher order aberrations, and the symptom speed scores. What about the devices we have in clinic? I'll focus on in-office and the at-home devices. But first, let's talk about the 6-headed interrelated mechanisms of meibomian gland dysfunction. There's 6 interrelated mechanisms, and they're all intimately related in the double vicious circle. All I did is I organized those 6 interrelated mechanisms into a little algorithm, categorized what we have in our toolkit across the top, and where you see stars, there's peer-reviewed literature demonstrating its benefit for that role. Notice that there's nothing that addresses all 6 heads of the beasto. That's why we layer on therapy. That's why there's a multidisciplinary approach. IPL decreases MMP9 and normalizes osmolarity. You see this in multiple peer-reviewed papers, and our own data shows the same thing. Here's an example of a chalazion patient. She wanted LASIK. You can see a high MMP9 on that bottom left pink line, and at each week we took another photograph and another MMP9, and we had nice resolution of her chalazion and her MMP9. The IPL can also impact the meibomian glands on a confocal level by improving the diameter, the acini, as well as the hyperreflectivity of presumed activated T cells. You can use IPL therapy to address inflammatory lid lesions such as acute and chronic chalazion in a injection-free and incision-free manner. We were able to show that IPL kills Demodex with IPL, which is exciting. What about lipoflow? Lipoflow can improve your ocular surface and change your keratometric readings such that 40% of the time your surgical plan may change. Symptomatosine just showed this work this year. Here's a patient of mine headed for cataract surgery. We did iLux on him, and a week later, you can see there's an improvement in his tear film stability and his keratopathy. Those linear streaks you see is because he cleaned out the garage that morning before he came in. What about tear care, the adhesive system? There's non-inferiority compared to LipiFlow, and importantly, the OSDI scores were more improved in the tear care group. So we layer all these things together in the office. Well, what about at home? There's mechanical lid hygiene assistant devices. I love them. Warm compresses are always a good idea. The vaulted night mask to help protect against corneal drying effects from inadequate lid closure at night. Don't forget about your megas, and then also neural stimulation devices are coming to the fore. Blepharitis has interesting implications in the preoperative cataract patient and may be correlated with increased risk of endophthalmitis. So what do we do about it? Well, there's lots of in-office treatments. There's one called the Zest, which is non-mechanical and has some really interesting anti-inflammatory properties. You know those lids are clean by the time you get done with this. There's mechanical versions of it as well. The AB Max and BlephX, both fantastic for mechanical debridement of the biofilm and Demodex burden of the eyelid margins. So in summary, we have lots of technologies and treatments that exist for our dry and MGD patients, external disease patients. Addressing the ocular surface preoperatively improves your refractive accuracy, and in-office and at-home approaches should be combined together for optimal patient results and outcomes. Thank you for your time.
Well, thank you guys so much, Zaina and Laura. Those were fantastic kickoff presentations for us this morning. I think we should talk for a few minutes right on the heels of that, Laura, about ocular surface in the face of cataract surgery, and then kind of transition to how that affects biometry and planning surgery with your talk, Zaina. For all of us, we're seeing a lot of patients in clinic, and we have a lot of patients who come in for wanting cataract surgery, and addressing ocular surface disease is so important ahead of time. It's expanded so much, Laura, as you've described so well, into such a broad field with so many different tests and treatments. I'm curious for the panel, for all of you, how do you manage that on a day-to-day basis in terms of working up cataract patients, and how far do you take dry eye before you decide to do cataract surgery, and where do you make these cutoffs, whether you go right to surgery or you put them through a dry eye treating process? Anybody want to jump in? Maybe Audrey, what's your kind of protocol?
Sure. Well, when I evaluate someone for cataract surgery, I get the biometry and then obviously look at the lids, look at the ocular surface. If I am noticing any significant dry eye, then I put them on some either lifitegrast or cyclosporin, dry eye treatment, managing blepharitis, etc. I do that for about 4 weeks, and then I have them come back and I repeat my biometry, and I also get, Penacam. I measure astigmatism in about 3 different ways, usually using Cassini Penacam as well as IOL Master 700 are the tools I have in my clinic. And then I compare the biometry, and if it looks like things are stable and clinically things have improved, then I proceed with cataract surgery. And if not, then, consider some other dry eye treatment modalities. But the biometry we have today, I'd say, is really mission critical for success.
Thanks. That all makes great sense and very practical way of thinking about it. Cindy, what are your go-to tools for screening dry eye more than just your clinical exam? And then how long does it typically take, or what are your go-to treatments to try to get them quickly through? Because they want to get the surgery done, they're anxious, and you want to kind of balance that. What are your thoughts?
Well, actually, these presentations so far were great, so thank you very much. I work up every cataract consult concomitantly also as a dry eye patient. So the 2 workups actually happen at the same time. My technicians are tasked to ask the questions like Laura mentioned, do the basic point of care tests like MMP9. We do that on everybody, tear osmolarity and my biography. Those are my go-to. I won't see a cataract consult without that. Depending on what data I get, then I titrate or customize my treatment based on the level of severity. And of course, getting them ready for cataract surgery, Rob, I use a more aggressive treatment modality or a group of modalities, meaning at-home remedies, many of the ones Laura mentioned, as well as paired with in-office procedures like LipiFlow, like BlephX, like iLux, whatever, IPL, whatever you have at hand, we do. This way we are ready and kind of jump-starting that tear film to be as homeostatic as possible to get good preoperative measurements for reliable surgical outcomes.
Thanks, Cindy. Laura, you're clearly such an amazing expert in this arena, and you've really helped so many doctors understand it better. For guys like myself and for other surgeons out there that maybe would like to do a better job at diagnosing dry eye and not just jumping into cataract surgery, there's so many things out there. What do you think would be just some key pearls from your talk, just for the average person's like, you know, I can do a better job? What diagnostics should they get? What should they do to help them get going in this arena?
Well, thank you for that amazing question. So it can be overwhelming. The rate of development of our new technologies is at a breakneck speed, and it can feel very overwhelming to our colleagues who are already so busy. So I really appreciate that question. So the good news is, I think it comes down to 3 really simple things, maybe 4. One, just follow the ASCRS algorithm. I think it's fantastic. That preoperative ocular surface disease screening, I think is so thoughtful, so well done, and it's easy to follow. So I think that's really great. And as far as technologies, I believe that osmolarity is very important in making sure that ocular surface is as reliable for your measurements as you think it's going to be, because of Alice Petrov's paper, and actually Dr. Matozzi was on that paper as well, showing that the keratometric readings can be off with hyperosmolarity. So I think that's an easy thing to dovetail in. It literally takes seconds, easy to delegate to your staff. And then finally, the MMP9, I find that test to be very helpful in addressing the inflammatory burden that you're dealing with before you go into surgery. And in fact, in the Ocular Surface Journal, just released yesterday, Victor Perez and Nakalua were able to show that MMP9 correlates with dry disease progression over time. So it becomes a target, something to get under control, that you can use and integrate to help set your patient up for success. Because cataract surgery is like putting a wedding ring on the rest of your lifetime vision. Maybe you should prepare for the big day a little bit.
That's a great analogy. And it's also a nice segue into what Zaina shared with us about all the advances in topography and biometry devices. Zaina, do you, I know that there's variability between, keratometric measurements and astigmatism magnitude and axis between different machines, whether it's a biometer that's doing some measurements or a topography device or a corneal evaluation device. And then you throw dry eye on top of that as another potential variable in these readings. How do you like to sort through all that? How many measurements do you need? How many different devices do you like to feel good in corroboration between different devices to make you feel good about moving forward with cataract surgery?
I think that's a great question, and it really kind of gets to the heart of the matter, is that it'd be great if we could use all of the technologies that we have, right? I mean, we're at Baylor. Luckily, we have almost every single topographer and biometer ever made. We have access to it. But realistically, in clinic, you cannot do every single measurement for every single patient and really get through, your clinic realistically. I believe having 2 topographers and a biometer, if you're trying to do kind of really high refractive cataract surgery with really excellent outcomes, is helpful. But truly having at least a topographer and a biometer, I think is necessary to be a refractive surgeon and to get great measurements, because, biometry, even though now we're getting better and better corneal measurements through your biometers, you can still miss some qualitative data that you get from topographers that you can see to rule out, things like keratoconus or ocular surface disease. I start my clinic with the printout of the placido ring from our Galilei, and I see that before I go and see the patient, so that my slit lamp exam is defined, where I need to look, and also to help decide if that patient needs something in terms of treatment prior to cataract surgery. But I think within 15 degrees for axis and within about 0.5 diopters for magnitude is important between these devices to comfortably put in a toric lens or a premium IOL. Otherwise, there has to be a reason for why that is.
That's great. I totally agree with you. It's so important to have these devices have similar results and to start thinking about dry eye, ocular surface disease, or some other irregularity if things are not adding up. And I don't think anybody really has the wherewithal to have two different biometer devices. So usually people either use the Lens Star or the IOL Master 500 or 700, and now maybe the Argos. But I agree with you, it might be overkill to have multiple biometry devices. But when it comes to the cornea, you need different types of technologies. Like you mentioned, Scheinfeld is one way of getting measurements. Placido is another way. So these are helpful at looking at. And Audrey, I know you do a lot of work in the space too. And we've talked about different ways of measuring the eye preoperatively. And let's talk about the OCT factor for the retina. What an important tool for decision-making in the refractive cataract surgery. And I know years ago, it wasn't even that long ago, the idea of having a retinal OCT as part of your cataract screening toolkit was like silly. And now for refractive cataract surgeons and general cataract surgeons, it's kind of becoming close to what I would almost think standard of care to see what's going on in the retina if you're going to make a decision about the optics to use. I'm not sure the IOL Master 700 has enough of a view of the foveal retina for me to make a good decision on. I'd rather have a full Cirrus or a full look OCT. Audrey, what do you do? Do you do that part of your pre-op workup?
Yeah, I also include that for pre-op workup, especially for, for premium IOLs, include OCT, because I agree with the 700. It's a nice basic MAC OCT, but you really don't get enough definition. Similar to needing a pentacam or other topography or tomography, you don't get enough definition with just the one device.
Thanks, Audrey. Cindy, any closing comments for this panel about getting patients ready for cataract surgery?
Yes, one really important point. Zaina, you mentioned that you look at the Placido disc. That is so important. So we as doctors have to let our technicians know to capture the real Placido disc before they flood the eye with artificial tears, because often technicians want to please their surgeons and want good readings, but that could be giving us false information. So if the Myers are really warped, we want to see that. Don't pre-treat with artificial tears right before you capture the image.
Great role. Well, panel, thank you so much. Awesome comments as always. Very appreciated. We are going to take this opportunity to move on to two more talks, and we are going to be hearing from Julie Schallhorn about corneal evaluations and what's essential, and also from George Waring IV on pre-op wavefront aberrometry and whether or not that is important. So we're going to start with Julie.
Hello, my name is Julie Schallhorn, and today I'm going to be talking about corneal evaluation, what is essential in refractive cataract surgery. These are my financial disclosures. I'm a consultant for Zeitz and Vanda Pharmaceuticals. I also have equity in Longbridge Medical. We are so fortunate today to have so many amazing devices that can tell us what is going on inside, around the eye, what's happening with it optically. While I love having all these with me in clinic, there's only a few things I think you truly have to do refractive cataract surgery. These are number 1, a good exam, number 2, corneal topography, number 3, OCT, and number 4, a modern biometer. The first and the fourth are going to be touched on at other times today, so I'm going to talk about corneal topography and OCT. Corneal topography, why is it so helpful? Well, let's back up and just talk about what Placido disc topography actually is. Placido disc topography is utilizing the cornea as a mirror to reflect a pattern of spaced out circles, basically. This gives us information about corneal curvature. It tells us about the pattern of corneal astigmatism, the location of corneal astigmatism, all of which are really important for surgical planning. Also, because it's utilizing the cornea as a mirror, it tells us about the quality of the reflecting surface of the eye. This tells us a lot about what is happening when light hits the eye, and it tells us about the reliability of the reflected image. Let's get started with the case. This is a 74-year-old female who comes in, longtime patient. She says, my vision is getting blurry. And, yeah, on exam, she's got a cataract and she really wants to be out of her glasses. She's been in glasses since she became presbyopic. She hates them and she wants that spectacle independence. You know, you've seen her several times before on exam, looks pretty stable, except she's got this new PSC and the NS is a little bit worse. But looking closely at the slit lamp, you see, what are these things right here? Gosh, you know, she does have some ABMD lines, but they're non-central. Are they bothering her vision that much? Is this going to be an issue for her, you know, undergoing cataract surgery? Well, you never know until you look. You do corneal topography, and here you go. She's got all types of irregular astigmatism. Her surface is nowhere near regular. And with this type of surface, she's not going to do well with a presbyopia correcting lens. This is something you have to normalize. Subtle exam findings can have a large effect on the refractive status of the cornea. You can't tell what they're going to do when you look at them, but when you use them during placidodistomography, you can get a much better idea about their impact on the refractive state of the eye. These things become very easy to see with topography, and they can prevent you from missing them on exam and making mistakes. This patient, pre-superficial keratectomy, cornea is very, very regular. Post-superficial keratectomy, she becomes much more regular. She has a significant reduction in her corneal cylinder, almost 0.5 diopters. She undergoes surgery with a Restore +3 in one eye and an active focus in the other eye. She's 20/20 in J1. This is a success story, and this is a story where using topography helps you improve her outcome and get her to where she wants to be. We know that epithelial issues such as Salzmann nodular dystrophy, epithelial basement membrane dystrophy can have a very, very large impact on the refractive state of the eye. This is a nice paper out of the Duke group looking at epithelial basement membrane dystrophy and Salzmann nodular dystrophy and its effect on both keratometry and IOL power calculations. You can see that IOL power calculations pre and post treatment change significantly over a diopter in some cases. Same thing with keratometry. These are the types of diseases that you do not want to miss if you're giving if you want to give the patient the best refractive outcome possible. And topography will help you get to that refractive target. Let's look at another case. This is a 53-year-old male. He comes in complaining of reduced visual acuity, never wore glasses, hates his readers. His manifest spherical equivalent close to 0. He's got a little bit of cataract. Is that giving him his visual problems? I don't know. Looking at his case, gosh, he's got kind of a lot of astigmatism on his keratometry though. What's going on? Again, you never know unless you look. On topography, this type of diagnosis is so obvious. We have all these leftover signs like Rizzuto's sign, Munson's signs to diagnose keratoconus from days when they didn't have topography. But on topography, this just comes out and whacks you over the head. This is the kind of patient where you're probably not going to do cataract surgery. This may be a new late progressing diagnosis of keratoconus. You want to follow them. Are they progressing? And if so, cross-link them. Topography provides you critical information that you can't get from biometry or the exam in this case. One last case here. This happened just at the VA last week when my residence grabs me. Hey, we're putting in the PanOptics now. I want to put a PanOptics in this patient. Okay, this patient's got a lot of astigmatism, you know. What's going on with their topography? Do you have their topography? Oh gosh, yeah, I do. They printed it out for me. It's right here. Not a great PanOptics candidate. Let's talk about why. Again, you know, keratometry on the biometer does not tell you the whole story. They don't tell you what is happening. It does not tell you what is happening on the surface of the eye, only at 2 different points. Topography for me is really an essential part of the corneal exam. Moving on to OCT, as much as I love my 90 diopter lens and as much as I love looking into the fundus of the eye, for me it is nowhere near equivalent having an OCT to truly see what is going on in the fundus. Again, a couple of cases. This is a 78-year-old male, happens to be a big university donor. He comes in, he's got a 3+ NS cataract, and he wants the best possible vision after surgery. He also doesn't want glasses if possible. His hobbies are reading and writing. In fact, he's working on a historical fiction novel right now. Looking in through his cataract, maybe he has a couple drusen, I can't really tell. Let's get an OCT to really evaluate the fundus. And he's got vitreomacular traction, as well as an epiretinal membrane, as well as drusen. I am not Donald Gass. I cannot look that well into the eye and see that they've got vitreomacular traction. When there's ever any doubt, use an OCT. It is so clear, night and day, no guesswork. And because of the potential effect of retinal pathology on outcomes after presbyopia correcting lenses, I think every patient with a presbyopia correcting IOL should get an OCT. Last case here, 52-year-old female. She previously had myope, she's had ICLs, now she's got significant ASC cataracts. She had a tough fundus exam though because of the cataracts, and looking in, Gosh, she's got some optic nerve cupping. Is that just a myopic nerve? I can't really tell. She wants spectacle independence, and I want to give her a trifocal IOL. But on OCT, this is what her nerves looks like. She's not a good candidate for that panoptics because she already has glaucoma and it may be fairly advanced. OCT can penetrate media opacities better than visible light. It can give you a better exam than your own eyes. Giving you all the information possible can help you make the best, safest choices with your patients. So in summary, to do refractive cataract surgery, you need to be able to achieve a good refractive outcome and ensure the patient has a healthy visual system. Topography and OCT provide information that you can't get in any other way. You want to combine a good exam and excellent biometry with these two modalities to give your patients the best results. Thank you.
Hi there, it's Dr. George Waring from the Waring Vision Institute in Mount Pleasant, South Carolina. I'm going to be speaking to you on preoperative aberrometry and do we need it? These are my financial disclosures. You know, probably the best known of the wavefront aberrometers is that of the Hartmann device. We now have access to high-resolution wavefront technology, which is very useful with the modern-day technology. And these technologies generate wavefront refractions, aberrometry, obviously, integrated corneal topography for registration, keratometry, and pupillometry. And here's just kind of an example of how we use this in our clinic, above and beyond driving our LASIK procedures. Here's a patient with an anterior stromal scar, and we can see the root mean square error of almost 0.6 microns, which is relatively heavy from this central anterior stromal scar. But what's interesting, you know, we actually can easily see the vertical coma just by looking at the axial and sagittal curvature map here down on the left. But it's nice to be able to quantify this and help us understand the impact on highly aberrated corneas from things like scars. Here's another technology that we found to be extraordinarily useful, the ray tracing and placido disc technology that has over 256 individual light rays that come through the entrance pupil that generate things like the dysfunctional lens index, help separate out internal from external aberrations, generate opacity maps, and also generate depth of focus curves. And it was Dr. Kelly Rocha that helped us understand the impact of higher order aberrations as they increase through life with the age-related cataract. And just recently, with Dr. Rocha and our group, we published the use of the depth of focus curve generated from these ray tracing devices, looking at the static and dynamic factors associated with extended depth of focus characteristics of monofocal intraocular lenses. And we can see the SIM Ks differ from wavefront Ks. With your SIM Ks, they're calculated based on different points at different radii, single points different. This is different from your wavefront Ks generated on a best Zernicke fit based on a central 4mm cornea. So this gives us different information of a wavefront guided refraction. And this device allows us to separate out internal from external aberrations through essentially subtraction of aberrations. And as we alluded to, the opacity map is also very useful. You can see the cortical spokes corresponding nicely with the opacity map. Now we have an objective way of generating this. Well, what is the dysfunctional lens index? This was a way to objectively measure the dysfunctional lens syndrome. And the dysfunctional lens syndrome was really just an attempt to characterize and standardize a triad of aging changes of the crystalline lens that are comprised of presbyopia, higher order aberrations, and lens opacities. And we further suggested a staging for this of stage 1 being presbyopia, stage 2 being early opacities, and stage 3 being a visually significant cataract. Now, the nice thing about the ray tracing technology is that it has this dysfunctional lens index that characterizes this based on the internal aberrations and then quantifies this and puts it on an index range from 0 to 10. Lower numbers mean reduced function. The cooler colors means improved, better function with a higher number. And then we have the internal visual simulator that shows the quality of the optics. And this is based again on internal higher order aberrations based on modulation transfer function compensated for pupil size. Here's an example of a stage 1 dysfunctional lens where in a patient who had prior LASIK a long time ago, and you can see top left corner, this really is an external lens problem affecting overall optical quality, not so much an internal dysfunctional lens problem. Here's a stage 2 dysfunctional lens where now this really is an internal optics problem. Therefore, we're staging at stage 2, where this patient would be better served with a refractive lens exchange if they were looking to correct their presbyopia, like both of these last 2 patients presented for. So here's a patient who has cataracts, or the 3rd stage of the dysfunctional lens, and you can see how poorly they score on their dysfunctional lens index, and that's why they are not seeing well. Well, here's another wonderful use in the post-op ray tracing toric check. Here is a patient who had monovision LASIK that had monovision IOL implantation with toric lenses with the left eye targeted for near, but a week later lost their near vision with residual astigmatism. So we performed the toric check, and you can see in the top left panel the toric lens axis at about 22 degrees, but the toric lens intended placement was 121 degrees, and that was the target axis. So this generates a treatment of 89-degree rotation to improve about a diopter change in the cylindrical power and a predicted post-refractive rotation, which we did, and you can see with a splendid result, restoring J1 uncorrected vision with exactly our target. And it's just so neat to see what this looks like post rotation after the positioning. Now I'd like to talk about one more technology. This is a double pass wavefront that measures internal light scatter as a surrogate for image quality, and we can, this actually goes a step further and generates an objective scatter index as a quality of vision objective metric. Here we have the point spread function of a clear lens, and you can see that this is my lens with excellent visual quality. And of 0.2 and a very nice pinpoint ray of light falling on my macula. But we've used this to help determine the stages over the years of the dysfunctional lens. You can see how the opacities of the nuclear sclerosis correlate with poor image quality and increased objective scatter index over the years with a green, yellow, and red that we usually term and look at and correlate with the different stages of dysfunction. So in summary, pre-op aberrometry is an important diagnostic consideration in the refractive cataract space. Hartmann-Shack now has high definition capabilities. The ray tracing technologies separate out internal from external aberrations, generating the dysfunctional lens index and post-op toric checks, and the double pass wavefront technologies help us qualify and quantify internal scatter and an objective scanner index. Thank you so much for your time and attention.
Wow, great presentations, Julie and George. Thank you so much for that. So now we'll have our panel discussion. I'd like to start off with Neil. Neil, Julie discussed reflection-based corneal topography and its many benefits. What about corneal tomography, Scheimpflug OCT? What roles do they play in your refractive cataract workup, if any?
Yeah, I must say that I rely primarily on surface topography imaging, but I do use tomography for several things. One is if there's a question of keratoconus, we have a Scheimpflug, the Penacam can give us a Balin algorithm, which helps us to interpret any subtle indications of keratoconus. I do use the Penacam to help compare astigmatic power and perhaps axis as well in some cases. It does give a look at the posterior corneal surface, so if there's anything that's really out of whack with the float, that might give an indication to take a second look and ensure that the posterior corneal surface is addressed. And if I'm doing an LRI, the pachymetry at the periphery of the cornea, as well as any potential irregularities in the peripheral cornea that might give a hint that I might get an unusual result from an LRI, can be helpful.
Great, excellent. George, what about you? Do you use tomography?
Mitch, we primarily use tomography. That's really our workhorse diagnostic device for both corneal and lens refractive surgery, and obviously cataract refractive surgery. We like utilizing some of the other imaging aspects of it, as you just saw in our presentation. We really utilize this in our advanced vision analysis, educating our patients about the opacities of their lens and kind of the various stages of dysfunction. So we just find that indispensable. And then also we find that it's much more forgiving for ocular surface abnormalities and still be able to generate useful data, particularly with dry eye and things of that nature. So yes, we use it, and this really is kind of a foundational device for our clinic.
Okay, Zaina, we discussed it a little briefly in the first panel. I know I've been saved in several cases with pre-op macular OCT. We have the benefit of that small or low resolution image on the biometer that you mentioned. How does OCT fit into your practice? Does everybody get one?
Yeah, definitely. I'm glad we got to talk a little bit more about it. I used to only do the OCT macula for my premium patients, but now it's actually part of my practice for every single cataract patient. It's important to remember you don't get paid for that. So it is something that, I'm using that isn't going to get reimbursed, but the positives of it definitely outweigh that. I've caught epiretinal membranes, drusen, a lot of things that, my clinical exam wouldn't have picked up necessarily. And it's changed my surgical management. So, and it's important to remember if you don't do it, and let's say there's an epiretinal membrane postoperatively, it's going to be your fault in terms of that patient. And, the IOL Master 700, I like it. It helps with fixation also to make sure that you're actually looking at the foveal aspect of it and can pick up something, but it has not replaced OCT macula for me.
Julie, anything you want to add beyond what you've told us already?
No, I think that, as a surgeon, it's really your job to really do the best to make sure your patient's going to have a successful outcome. So, anything you think you need to be able to do that is really, really important.
Great. George, I think you, for the first time in my experience, really clearly laid out the applications for aberration measurement in cataract surgery. So to help me, internal aberrations include both the posterior cornea and the lens. So does the posterior cornea component even matter in aberrations? What about with toric IOL adjustment that you discussed?
Mitch, it's a great question, and I think historically it's just so amazing to me, with the work that was done at your center, and I think this is just really one of the most important contributions in decades to our space. And thank you for all of yours and Doug's and everyone else involved's efforts on understanding posterior corneal role and internal astigmatism. I think before that, most of us thought this was lens-based astigmatism, and now I think most of us would agree it's actually primarily posterior corneal astigmatism. However, we do believe that lens astigmatism, in terms of etiology, still exists. So I think of this in two buckets in terms of preoperative aberrations. You've got internal aberrations in terms of visual quality and understanding perhaps where the bulk of the visual disturbance is and separating that out internally and externally. And in that realm, I believe that the lens contribution makes a massive difference, and we really should be focused and thinking more about lens-based internal aberrations. That's a little different than low-order astigmatism measured by wavefront, where that's what's driving our decision-making for things like the post-op toric check that I showed you. That's an extraordinarily powerful tool to have in your toolbox with the click of a button and an undilated eye. If you're ever wondering if somebody's not seeing as well as they should be with a toric, you just take a picture and it basically shows you. Now, of course, you can go confirm your measurements with Berdahl and Hardin calculators prior to making a surgical decision and planning, but very useful. But in that setting, that really is primarily posterior cornea.
Neil, any final words on corneal asphericity with IOL choice?
You know, I find myself lately putting in more and more spherical IOLs for patients who are desiring near or arm's length vision. And so I think understanding, you know, are you going to target a little bit of spherical aberration actually maybe to help with depth of field? And I think getting some clarity on the wavefront mechanics, if you will, of the eye can help target that.
Great, thank you. Thanks, panel. I think we're going to move on to our next three speakers. We have Audrey Talley-Rostov, who will talk about femtosecond laser-assisted cataract surgery. What do patients want? Vance Thompson, who will discuss Zepto for the use of capsulorhexis creation. And then Rob, who will finish up talking about operating microscopes and what's new with that technology.
Hi, I'm Audrey Rostov, and I'm going to be talking to you today about femtosecond laser-assisted cataract surgery. What do patients want? Here are my financial disclosures. I'm going to be talking about a number of products from a number of these different companies, but I have no direct financial interest. So what do patients want? Well, it's pretty simple. They want great outcomes and safe procedures. How does Flax meet these objectives? We will be talking about the following topics. For refractive surgery patients, once a refractive surgery patient, always a refractive surgery patient. Any patients with a previous history of laser vision correction, phakic IOLs, or RK have very high expectations. Here in the video, you can see that I am removing an ICL that a patient had who then subsequently developed a cataract. The femtosecond laser treatment that I did easily goes right through the ICL. You can see I have a perfectly centered capsulotomy. I also did phacofragmentation, which allows for very easy nuclear disassembly. And then for this patient, we decided to put in an extended depth of focus lens. Remember, all refractive surgery patients are always refractive surgery patients. And it's really important to try and nail that refractive outcome for them. They had refractive surgery for a reason the first time, and they're going to expect the same the second time around. Cataract surgery is refractive surgery, and this is especially true again for premium IOLs. Capsulotomy size matters. All of the different laser companies have shown that laser capsulotomies are more accurate than manual capsulotomies, and although this is an old slide, you can see the data there. Why does this matter? Well, a capsulotomy can affect effective lens position. If you have a 4mm capsulorhexis, this can result in a longer effective lens position compared with a 6mm capsulotomy. If a lens is 0.5 millimeter posterior to the assumed plane, then a 21 diopter lens will produce only 20 diopters of correction, and the converse is also true. When we talk about astigmatism correction with Flax, there are a number of different ways you can use Flax. This happens to be the LENSAR system, and there are these little capsular nubs or tabs where you can orient exactly your toric IOL. The center photo shows with the blue arrows the little capsular nubs, and this also shows that it was a patient who had a lens coloboma. And so you can center the capsulotomy in the center of the bag, as well as doing the capsular nubs for toric alignment. Here you see I'm going to be implanting a monofocal toric IOL, and this is one of those custom capsulotomies with little capsular nubs or tabs, and it's very, very easy no matter which form of IOL, no matter which type of toric IOL you use. It's very, very easy to just center that very easily on those capsular nubs. This is another video of a patient who had a different femtosecond laser done. This was a patient with a previous PK. You can see I also did femtosecond laser incisions here. They're corneal relaxing incisions in the cornea for additional astigmatism result. And This patient had this toric lens. You can see those 3 little dots there. I'm going to be aligning with intrastromal markings. And so that's another way of using femtosecond laser to align your toric IOLs. Imaging is very helpful. All of the different systems have imaging, either using OCT or rotating Scheimpflug imaging. This can give you information on the density of cataracts, the position of the lens, the thickness of the lens, and also if there's zonular compromise or something like a posterior capsular rupture. With zonular compromise, you have the ability to center the capsulotomy on the bag. This causes minimal stress on the zonules, and you can get real-time imaging. And the center photo shows that I am actually moving the capsulotomy to center on the bag. In cases of endothelial compromise, whether that's a previous PK or Fuchs dystrophy, this is also a safe procedure to use the femtosecond laser. It results in less effective phacoemulsification power and less endothelial cell loss. Dense cataracts, you can also use a femto treatment here. You can get a perfect capsulotomy and avoid that Argentinian flag sign, which I really only enjoy seeing in South America. Here we see I'm doing the capsulotomy, and also you can see the phacoemulsification here, the cataract surgery performed after flax. The left photo shows the density of the cataract, and you can see that is an extremely dense cataract that was there. And in the right, the video is starting the cataract surgery. We have a perfect capsulotomy, no Argentinian flag sign, and there is some nuclear disassembly. So it's also good for intumescent cataracts. In summary, flax is good for premium IOLs, after phakic IOLs, patients with zonular compromise. It minimizes endothelial cell loss. You can use it with dense or traumatic cataracts and provide great outcomes and safe procedures, which is what your patients want. Thank you.
Hello, Dr. Vance Thompson here. Happy to be on 20 Happy, talking about Zepto, precision pulse capsulotomy, how and when. And I am a consultant for Centricity, the makers of Zepto. And in cataract surgery, we really want to center not only the implant, but the capsulotomy with regards to 360 degrees of overlap of that anterior capsule for long-term implant centration and stability. We can make a capsulotomy with the laser, manually, or with Zepto. I'm going to be talking mainly about Zepto, which has a capsulotomy tip that's housed in a soft silicone suction cup with a nitinol ring, which is really where the action happens. And a 4.4 millimeter diameter ring gives about a 5.2 millimeter diameter capsulotomy. And there's a great area in the center so that you can center this beautifully in cataract surgery. And suction pulls the capsule against the nitinol ring, and then a small pulse of energy, very quick, hence the name Zepto, of about 4 milliseconds creates the capsulotomy. We know in the capsule of the lens, the germinative zone of the lens epithelial cells has a lot of mitotic activity. And so in cataract surgery, if we don't overlap the implant with the capsule, it can fuse to the posterior capsule and create a sequence of events of capsular fibrosis that can tilt and decenter the lens. And that's why we want to get 360 degrees of even capsule overlap. And this has been well published in the past by David Apple and others, that if you get overlap, you get this less aggressive form of PCO, and how apposition of the anterior capsule, the posterior capsule, can create a very aggressive, even dangerous fibrotic response that Alan Carlson also showed can be actually progressive, with a progressive decentration and tilting of the implant that we really want to prevent, because if it happens for 360 degrees, you get what I like to call capsular fusion syndrome, and you don't want it. So how do we achieve this? Well, Professor Purkinje, way back when, who described the Purkinje fibers in our central nervous system, also described the Purkinje images of the eye. And the French ophthalmologist Sanson is also credited with helping with describing these light reflexes that are in surgery every time and can be very helpful. And Purkinje 1 is a reflection off the anterior cornea, Purkinje 2 posterior cornea, Purkinje 3 anterior lens. And since those three surfaces are all convex, these are upright reflected images. Purkinje 4 off the posterior capsule comes off a concave surface and is inverted. And in cataract surgery, I mainly use Purkinje 1 and Purkinje 4, the upright and the inverted images, to help center the capsulotomy and the implant. And so you can see here that we have the brightest first Purkinje image that's coming off the cornea. I just pointed to the third Purkinje image that's in the vitreous. That's not real useful clinically. But you can see the fourth Purkinje image right behind the first. And when we align those, we're very close to the patient's visual axis. The first Purkinje image has been described as the subject-fixated, coaxially sighted corneal light reflex in a great paper by Chang and Waring for centering refractive treatments. And it can be very helpful when the patient fixates well. But if the patient doesn't fixate well, like the left image or the very right image, we can't center on that first Purkinje image. In the middle, when you see the first and the fourth in a very consistent relationship, we can center now because we know the patient's fixating well. And so that fourth image in a relationship like this with the first Purkinje image is very helpful. So someone like this patient who was sedated and has a Bell's phenomenon going on, I could not get them to look at the light. And you never see a vertical separation in the Purkinje images. It's typically a horizontal separation, if anything. So you know that they're not fixating if you have a vertical separation like this. So since they weren't able to do it due to the anesthesia, I just use my 0.12s to align the first and the fourth, and then I can center both my capsulotomy and my implant. So doing the Zepto capsulotomy, we can create a very nice opening, and it has an edge that's slightly curled up. And on scanning electron microscopy, this is how it looks. And that is a smooth component. And then you compare it to a capsular rhexis. They're both two quality openings. But when you compare the edge strength of a capsular rhexis, above you can see it will tear more quickly than below with the Zepto in this paired cadaver eye study. And you can see it took more energy to create a tear in the Zepto capsulotomy. And in this paired study, Zepto in red was stronger than Femto and capsular rhexis. You will see kind of the cut edges of the collagen immediately post-op, and then here 3 weeks post-op in this light adjustable lens, it's nice and smooth. This technique has been described in the Journal of Cataract and Refractive Surgery and can be reproducible in surgery with the Zepto capsulotomy device, that you have a push rod that you extend it so that you can place it through the incision. And here you can see me placing it through the incision with 0.12 fixation, centering on the first and fourth Purkinje image aligned images, achieving suction, making sure that the push rod is fully withdrawn from the throat of the device, and then delivering the energy. And then we have a nice free-floating capsulotomy. Then we place, in this case, the multifocal implant, And I really believe that sometimes you have to rotate and push to find that happy spot. And you can see how nicely this centered with great capsular overlap. And this patient did absolutely beautiful. So that's how the Zepto capsulotomy device can help center cataract surgery on the visual axis. Thank you.
This is Robert Weinstock, MD, and this is an update on 3D visualization platforms. My financial disclosures are here. I'm a consultant for Alcon, Zeiss, Bausch, J&J, and Bionics, relevant to this discussion. As many of us are starting to witness, we are undergoing a paradigm shift in the way we do surgery. Heads-up digitally enhanced microscopic surgery is here, and there are now multiple platforms in this space. Some of the benefits are better images and the ability to operate under higher magnification and image augmentation, improved ergonomics and comfortable positioning for the surgeon as well as other people in the operating room, surgical guidance and overlay software that can be placed on the screen or in the image to help guide surgery, advances in collaboration and education as other surgeons and other people can see exactly what the surgeon is seeing and collaborate with them and learn. And of course, it's an entirely new way of viewing the surgical field with new information available and a new communication experience. There is peer-reviewed data that is beginning to be released as more and more surgeons are using it. This is an example of a study that we did in the Journal of Refractive Surgery recently in 2019, comparing conventional surgery to 3D heads-up surgeries, showing no difference in surgical time or complications. The first device that came to market was the Ingenuity system, formerly TrueVision. As you can see, it's a large screen that the surgeon can look at, either placed at the foot of the bed if they operate superiorly or across the bed if they operate temporally. And this device can be hooked to, this 3D camera can be hooked to any microscope or be built in on a Alcon Luxor scope integrated. The surgeon can sit back in a comfortable position. There's no oculars on the scope. Fellows, residents, industry people, scrub techs, anybody who wants to watch can see exactly what the surgeon is seeing as they operate. And things can be placed on the screen, like the data here from the phaco or the vitrectomy unit can be placed to guide the surgeon on their settings. Here's an early generation video of the system, and you can see here me using intraoperative aberrometry in a side-by-side feature where I can see the surgical field on the screen looking straight ahead, and we can actually swap back and forth to make intraoperative aberrometry larger in a bigger format to help guide toric IOL placement here and look at the streaming live refraction of the eye during surgery for IOL positioning. Here's an example of another surgeon operating with a 3D system. This is kind of the current setup with the 3D camera hooked up to a Zeiss scope actually, and the surgeon sitting back, operating comfortably, beautiful view of the surgical field in 3D. This happens to be my father. He's a 78-year-old surgeon for any of those who think that they can't adjust to this. Here's evidence of a well-seasoned ophthalmologist, been in practice 40 years, who's now operating heads up on a regular basis. The second device I'd like to talk about is the Zeiss Artivo 800, and this is a new ground-up microscope developed by Zeiss that is the similar type of features where you have a large screen that you can look at during surgery and a newly designed microscope without oculars on it. This provides similar high-resolution, excellent imaging of the eye with overlays possible and all sorts of digital enhancements available on the screen. There can be guidance for toric IOLs with their system, as well as intraoperative OCT for retina procedures. There is the ability to put the oculars on. Most surgeons don't, but if somebody wants to, as they transition to 3D heads-up surgery, they can place oculars on the microscope, and this is also available on the Ingenuity system. The most recent development in this space is by a company called Bionics, and this is based on fighter jet technology, basically, that the fighter jet pilots use to augment their images of what they see. And this company is now applying this to surgery with a ground-up microscope that's been developed and a headset. Right now it's tethered by wire, but it's soon to be a wireless headset that is going to be used. This microscope has a very small footprint, and the headset is extremely comfortable to wear with adjustments available to help it fit on a surgeon's head. It creates a 3D immersive experience and amazing ergonomics because you don't have to actually look at a screen. You can move your head in any position while you're operating. And with small head movements, actually, with this recognition that the headset has, you can control X, Y, Z, you can control zooming in and out, and you can control magnification just by movements of your head in different directions. And also, the overlay of other things can be swiped in and out on your screen using your head movements, which is very unique. So there is a lot of capabilities, of course, for this technology as well, including intraoperative OCT, parameters from the phaco machine or vitrectomy machine placed on the field in your view, and other guidance applications. It also has the potential to be connected to preoperative devices, so you can see different images of devices that have been images that have been captured preoperatively, whether it's OCT, other diagnostic devices like topography, are all going to be able to be visualized in your headset, in your view as you operate. And of course, intraoperative devices also, like the phaco machine parameters as well as intraoperative aberrometry, could be imported into the surgeon's view. And then this could all be connected to the cloud and the EHR system for communication, recording, and documentation. We were fortunate enough to do the first case in the United States recently with this device. And here you can see me operating very comfortably, efficiently with the system on my head. I'm in a nice posture, comfortable position. Removing the nucleus here, you can see the footprint of the surgical microscope from two different angles here. And basically, we accomplished about 50 cataract surgeries over about 3 days using the system without a problem. We had to obtain IRB because this was just prior to its 510K approval, but is now going to become commercially available here in the United States and throughout the world for operating for eye surgery. So that concludes this talk. Thank you very much.
All right, well, thanks, panel. Thanks for the amazing talks on amazing new technology and some of the more kind of higher tech side of refractive cataract surgery, which continues to really blossom and explode. I think it gets overwhelming sometimes, all the different new toys and technologies that we have are disposable, not just preoperatively that we talked about earlier, but both now intraoperatively. Vance, you are the senior statesman on the panel, although you are quite young and look quite young, as always, and good. What do you think about the changing landscape of the surgical arena and all the things that have happened in the last 10 to 15 years to making our lives easier and better?
Well, what I love is that surgeons have choices. And, whether they're more traditional or more advanced, I think that, technology transitions are an interesting time to, assess your own comfort level, maybe get back into the wet lab and make sure you're nice and comfortable. But it just makes it so exciting. And what I just saw on your headset, I felt like I just saw the future. But the choices are absolutely, stunning. Even, in my talk, talking about the capsulotomy, a manual capsulotomy still works great. A femto is amazing, and a zepto is a great addition. So this idea of choices and how do we optimize, and the more sophisticated these implants get, the more important it is to optimize. But the surgical arena is such an enjoyable place, but one that does take work to keep up with these technology advancements.
Yeah, well put. George, what do you think about just this movement towards automated surgery, whether it's with the Zepto, femtosecond laser, augmentation of your image and guidance tools in the operating room? Is this the future of ophthalmic surgery, moving more and more towards robotic surgery?
You know, Rob, it seems to be, and when we look through our retrospective scope, which is important to do, we've seen this evolution in things like corneal refractive surgery with the use of femtosecond lasers for cutting our lamellar LASIK flaps, and you just, many of us were involved in watching that journey and understanding why more than 3/4 of the LASIK flaps cut in the United States are now done in an automated fashion, that is with a laser, with femtosecond laser. And so you just wonder, is that the future for lens-based surgery too, whether it's through automation with Zepto or femtosecond enabled? But Vance said it so well, the manual capsulotomy is incredible as well. And it's wonderful because we can help simply, or we can help in an advanced way. And at the end of the day, it's really data. But when we take your talk and incorporate that, and then look at things like what Audrey presented, what Vance presented, and think about where does this fit in the ecosystem of the future, this, like you laid out, Rob, this could all work together. We might be operating from home. I mean, it's just unbelievable. And in the pandemic current state, that's not out of the realm of possibility. We're going to be building clinics differently. We're going to be interacting with our patients, and as you can tell, with each other differently. And we're going to be operating differently. This is the future, and I'm just really excited about all the technology you all presented, and having the opportunity to use it.
Thanks, George. Audrey, you are such an innovator, and you have pioneered so many new technologies and been an early adopter. What drives you internally to take on that challenge? And then what is the biggest impact for you and your personally and for your patients?
I love to see what's new and how we could do things better, building the better proverbial mousetrap, so to speak. And I think it's really exciting to have a culture of continuous learning and to really see how we can help our patients more and help our patients better. And I mean, there's nothing better, as you know, than when we see that patient post-op day one who's 20/20 after smile, or see them smile, right? Or after, LASIK, or after a premium IOL, no matter which you choose. And when you have that patient crying happy tears and they're really 20 over happy, I mean, that's what drives us all to become better surgeons and provide better outcomes. And there's a variety of techniques, and depends on your resources and, where you are. But I think it's, as Vance said, it's amazing to have choices and to really zoom into the future with all of these different technologies.
Yeah, it's true. It really is an exciting time. And there's a bit of a subliminal process that goes on. I think when you start using these new technologies and get good at them, they actually start to take the burden off of you a little bit of some of the maneuvers. Like, you don't have to concentrate on so hard on the manual rexes and be aware of the patient moving their head or something bad happening. Same by softening up the nucleus with femtosecond laser, or having those, capsular nubs that you have at your disposal, instead of like worrying about an ink mark bleeding or aligning a lens. With the heads-up surgery, you're more comfortable. You're in a better posture. You're not operating where you might have a pain in your back or neck. And I think that there's a lot of this technology actually making our lives easier as surgeons that have an indirect result or a direct result on our patients having better outcomes. Because if you're stressed and you're challenged case after case, that adds up over a day and over a week and over a month. And you don't perform as well. It's well proven if you're under stress and you're challenged and exhausted. Does that resonate, Laura? Do those things, you think, translate into better outcomes for patients?
I would suspect so. I think it's easy to forget that we're humans, and there's a limit to what we can do. And I think anything you can do to set yourself up for success will lead to setting the patients up for success.
Yeah, thanks. Well, we could talk for hours on new technology in the OR and take deep dives on it, but I think this was a really nice overview of some of the things that are going on right now and stuff to look forward to. And hopefully everybody listening can start to digest it and consider what might make their lives easier in the operating room and what might make it better for their patients. So we are going, thank you panel so much. That was a great session. We are going to continue to do some talks, and we are going to move on and have some talks here first by Cynthia Matosian on sustained release drug delivery. And then we will have Neil Shorstein tell us about dropless cataract surgery, which should be fascinating. So thank you.
I'm Cynthia Matosian from Matosian Eye Associates. I'm going to speak about sustained release drug delivery. These are my financial disclosures. We have come such a long way with innovations in cataract surgery, with amazing IOL options, very accurate IOL formulas, intraoperative guidance systems, amazing phaco equipment. So why not also consider new drug delivery at the time of cataract surgery? Patients are paying for their premium implants. They're expecting premium outcomes basically as they're getting rolled out of the OR, and they're really looking for that premium experience. However, about 75%, 76% of ophthalmologists are still prescribing topical postoperative medications. Patients perceive topical drops as a nuisance, as a burden. Their caregivers do as well. We know patients are notoriously bad at putting drops in their eyes, and there are all kinds of issues with callbacks from pharmacies regarding branded products. Actually, if we look at the three typically prescribed products, a steroid, an NSAID, and an antibiotic, each is used at a different frequency over a different number of days or weeks, leading to about 105 drops per eye. And if the second eye surgery is done within a week or two of eye number one, there's an asynchronous regimen going on, which really leads to confusion and poor compliance. Patients have trouble remembering placing the drops in. They don't get the drop in. They have issues with manual dexterity and forgetfulness. Many just abandon their drop regimen. So what are some of the options available to us as ophthalmologists? We can either place the drug inside the eye as prophylaxis against infection or inflammation, or place it into the inferior punctum pre-surgery, during surgery, or after surgery. The benefits are numerous. First, it's a hands-free treatment in our COVID era. It bypasses the cornea, and it takes compliance out of the hands of the patients and puts the responsibility back in the surgeon's hands. One of the challenges that we face as cataract surgeon is the unexpected miosis that happens in about 1 out of 4 patients. We know that when the pupil constricts, there are complications associated with that. There is a product that's FDA approved, phenylephrine and ketorolac, and a solution that is mixed into the BSS bottle at the start of surgery. And it's used as a continuous irrigation throughout the entire case. It decreases iris prolapse, it reduces CME and breakthrough iritis. As you can see from these data, it decreases pupil expanding device usage during surgery. The middle data is my own data, and it decreases surgical time as well. Recent studies have also demonstrated decreased pain, not only during the surgery, but in the immediate post-operative period, as well as a decreased CME rate and breakthrough iritis issues. Another alternative is placing dexamethasone intraocular suspension 9% into the eye at the conclusion of cataract surgery. This is my video. At the end When the IOL is in, well positioned, OVD is out. Stromal hydrate the main incision and pressurize the globe to where you want the globe to be at the end of the case. Make sure it's well sealed. Then go in through the side port with a cannula. Place the tip under the iris. Push the plunger with your thumb and snap back. As you can see, it's very quick. I'm going to show it to you again in halftime. Go in with a 25 or 27 gauge cannula through the side port. Place the tip under the iris and snap your hand back. Some surgeons are placing the dexamethasone spherule now into the capsular bag in order to sequester it in place and to minimize its migration onto the optic surface. From the clinical data, we can see that there is statistically significant decrease in anterior chamber cell clearance, and this was maintained out to 30 days. When we look at IOP, it's very stable all the way out to 90 days. An alternative option of delivering a steroid at the time of cataract surgery is by placing an insert into the inferior punctum. As you can see from this graph, it is activated when it hits moisture and then releases the drug over 30 days, similar to the intraocular spherule. It can be visualized using a cobalt blue light and flushed out if necessary. This is my video of a patient who happened to have two puncta. First, I had to figure out which one was the patent one. And for this procedure, use a punctal dilator, go in not just vertically, but also horizontally. And while you're dilating, rotate the dilator back and forth between your thumb and fingers. Then dry the area with a Weck-Cel because the sponge expands as soon as it hits water. And once you get the implant in place, push it all the way so there is no exposed tip, and push it all the way in and you're done. It's easy to do, and over 30 days it bioerodes as it releases the dexamethasone. In the studies, it showed not only a decrease in pain, but an absence of anterior chamber cells, as you can see in these graphs. In terms of IOP, it was very stable all the way up to 30 days. In summary, there are so many benefits to alternative drug delivery, from bypassing the cornea and being gentler on the epithelium to lifting the drop burden from patients and their caregivers, and to delivering a bigger wow on postoperative day one. Thank you very much.
Thank you, panelists, for the opportunity to present our drop-free technique that a group of us at Kaiser Permanente started in 2008. I have no financial interest to disclose. Drugs discussed are off-label. Our current regimen is to inject lidofen at the start of cataract surgery. Intracameral moxifloxacin 0.1% at the end of surgery, injecting at least 0.5 mLs. Some surgeons use 0.1 ml of cefuroxime instead. We use the antibiotic for stromal hydration since a recent study shows antibiotic persists for about 24 hours in the wound. And subconjunctival triamcinolone injecting 4 milligrams at least 5 millimeters inferior to the limbus, and no perioperative steroid or NSAID. So the only eye drop related to surgery the patient receives is a supplemental dilation drop in the pre-op holding area. The trouble with drops is that the patient may fail to instill them for a variety of reasons. The dropper and potentially the eye surface can get contaminated. Abrasions are known to occur with relative frequency. And studies have shown that drop installation is related to emerging resistance of bacteria. And drops can be expensive for the patient. On study in the JCRS showed that 93% of drop-naive patients instill drops incorrectly. Bacterial resistance can emerge if drops are instilled for too long a period of time, too short a period of time, and repeatedly over time. Let's take a closer look to understand the methods for this drop-free madness. For antibiotic coverage, we're using moxifloxacin 0.1%, first for stromal hydration, as you just saw, and then 0.5 mLs for intracameral injection, approximating the replacement of aqueous with drug. These are the studies showing the very low rates of infection with antibiotic injection and no drops. A meta-analysis concluded that there was no supporting evidence that post-op topical antibiotics lower the risk of endophthalmitis. This Swedish study, where all eyes received cefuroxime injection, found no statistical difference in endophthalmitis whether the patient was prescribed drops or not. For inflammation control, we're using the commercially available dilute form of triamcinolone, injecting 4 milligrams, 5 millimeters inferior to the inferior limbus. These are the numerous studies examining various steroid injections in cataract surgery. Now, focusing on comparative studies using triamcinolone, the uniform result is for similar or better inflammation control with injection compared to topical steroid, or steroid plus NSAID in the prospective European pre-med study. In fact, in that study, in patients with diabetes, no eyes in the injection group developed CME. IOP was higher, no doubt related to the higher dose of steroid injected subconjunctivally. Why is dose and location of injection important for IOP? This slide shows the location and dose of injection in these studies. Notice the lower doses injected closer to the limbus in these studies and higher doses injected more posteriorly, often in the subtenon space, in these studies. This elegant study by Xu et al. Shows that injecting steroid closer to the limbus produces a higher concentration of steroid and aqueous and a higher mean IOP at 3 months than the same dose injected more posteriorly with a lower aqueous concentration and a lower mean IOP. So injecting more anteriorly intuitively addresses pain and iritis and resulting CME, but has increased risk of higher IOP, while injecting more posteriorly should target the macula better, with less chance of IOP spike, but perhaps at the expense of better pain and iritis control. Chang et al. Reported patient age younger than 65 and axial length longer than 29 millimeters are important risk factors for IOP steroid response. We began in 2008 injecting concentrated triamcinolone 5 millimeters from the limbus and reported a small number of IOP spikes. When we switched to using the same dose but with more volume of the dilute drug at that location, we had fewer IOP spikes. We continue to use this method. If the concentrated drug were to be used, because of the Xu study, we believe injecting farther from the limbus might produce less IOP spikes than we had in our initial study. You can see the white stripe of the depot inferiorly in both eyes of this patient who had bilateral same-day surgery a week prior. This patient had injection of concentrated drug a week prior. The depot is denser and more concentrated. This patient with a postoperative IOP spike weeks after surgery received the dilute drug injection 5 to 6 millimeters superiorly. The depot has migrated closer to the limbus, now about 2 millimeters away. Because of the potential for depot migration, I no longer inject superiorly. The most common problems with steroid injection is conjunctival hemorrhage. Acutely, this is caused by nicking a blood vessel on injection. This may be minimized by visualizing the needle tip and avoiding large vessels. Late hemorrhage months later can occur and recur once or twice in less than 1% of patients. No treatment is needed except for patient reassurance. Reflux of drug on injection can be prevented by tunneling the needle and injecting slowly. I do provide written instruction to the patient about the presence of the white depot as the long-acting medicine, in addition to advising about the possibility of hemorrhages. IOP spikes are uncommon, and I emphasize the 1-month checkup with our optometrist and inject with caution in patients with advanced glaucoma, younger age, and longer axial lengths. Finally, it is important when going drop-free to ensure that povidone iodine is properly instilled, the wound is well constructed, the eye is appropriately pressurized at the end of surgery since IOP may decline in the hours after surgery, and stromal hydration is employed, preferably with antibiotic. Thank you for your attention.
Great. Thank you, Cynthia and Neil. Very nice summaries of the medication issues we deal with daily. As you know, a lot of what we discussed today is invisible to our patients, but medication use is something that's literally right in their face. And their experience with this can really affect their overall satisfaction with their surgical experience. Cynthia gave a great summary of the sustained release drug delivery options that are currently available. Vance, have you incorporated these into your standard regimen? And if so, which ones? And do you have any tips for managing the economic and insurance challenges that they present?
We, for a few years, have been injecting intracameral antibiotic and steroid and non-steroidal, and then using post-operative combination drops. And we have not been able to figure out, how to bill for the intracameral, but we are so convinced that it's the right thing to do based on talks like Cynthia's, that we actually just cover that cost.
Okay. Cynthia, any follow-up to that? We know that, like Dextenza, Dexacu, they require that pre-approval process. How have you kind of worked around those issues?
Well, we try to identify the patients, and both companies work very closely with the surgical coordinators or whoever is tasked in your office to handle this. And there is extra work. The surgery center orders the product, and the charts are actually labeled ahead of time so we know which patient gets what. Otherwise, there could potentially be confusion. But both companies have a fund that will help supplement by either replacing the drug or making it work if inadvertently a patient gets a product who happens not to be covered. The key, though, is to, especially for the Dexacu product, let the patient, their caregivers, and the co-managing optometrists know that there's this little white pearl inside the eye in case it migrates or gets stuck onto the optic or on the surface of the iris, so nobody panics and thinks it's early or new onset endophthalmitis.
Okay. Julie, intracameral antibiotics are steadily increasing in popularity. We currently use intracameral Vigamox. Neil presented some really compelling evidence for abandoning post-op antibiotic drops. I personally have not been able to pull that trigger. I really want to. What's your protocol, and are you considering it?
Yeah, so we switched over when the European data came out on endophthalmitis rates. We switched over to doing intracameral cefuroxime, and we do Vigamox for penicillin-resistant patients or penicillin allergic. I agree with you. I am in exactly your same boat. I know that, mentally and logically and medically, it should be fine to not give these patients topical antibiotics afterwards. I personally have I have not actually been able to stop doing that. And it's something that I think that I just need to bite the bullet and do. We all have things that we cling on to as little security blankets, and I feel like post-operative antibiotics are a little bit of a security blanket for me in my practice. But it is something that, for all the reasons that everybody shared, is a practice I think we should be moving away from.
Yeah, Neil, I've heard Francis Ma talk about this too in the past. Is there any advice you can give us all in helping us with that transition?
Well, it does take a leap of faith, but if you really believe the science, if you believe the evidence, then it's reassuring. We did a study at Kaiser Permanente a few years ago, published in Ophthalmology, and we found that actually when we compared the patients who had cefuroxime at that time only versus the patients that had the intracameral plus the topicals, the endophthalmitis rate was actually a little bit higher in the group that had the intracamerals plus the topicals. Now, it wasn't statistically significant, but it was suggestive, surely, that the topicals really didn't help, and that's been borne out by several studies, but also that maybe there is a problem with patients, trying to instill the topical drops, and maybe, with hand hygiene or with the micro traumas of the eyedropper tip, it's not only not beneficial, but it actually can be detrimental. So that really cinched it for me.
That's such a great point. I think you've convinced me. I think that's probably I'm going to take it out of my post-op protocol.
Starting Monday. Okay. Cynthia, we haven't discussed less drops. Vance talked a little bit about combined compounded medications for intra-op use, intracameral transonular injection. Are you using any of those, or do you know anybody? Any comments on the utility, downsides, practice patterns, et cetera?
Well, I'll go back. I used to do transonular back in the day, but I stopped doing that once the alternative options became available in order to avoid that white, cloudy, asteroid hyalosis looking like vitreous for a few days. The compounded drops are becoming more and more popular. There are 2 or 3 companies that are doing this, and it takes some coordination. The problem with it, as I see it, is that either antibiotics are being used for too long of a period of time because they're combined with a steroid and an NSAID, because the doctors want the NSAID and steroids to be used at 2-3 weeks. But if the antibiotic is in the bottle as well, then everything is being used for somewhat an incorrect period of time. On the other hand, some doctors are ordering the antibiotics separately and then using the steroid/NSAID drops compounded for a longer time. You just have to see what works best in your practice to minimize the callbacks, which really gobble up huge amounts of technician time.
Vance, any comments on this subject as well?
Well, we love the intracameral, we love the subconj, and I guess we're kind of where Julie used to be. We still use drops, and we love the combination drops, and we actually love the simplicity value. We use them for, the combination drops for post LASIK without the nonsteroidal, and we use combination drops with the nonsteroidal for post cataract. And we have loved the simplicity value, but I agree with some of the concerns that Cynthia talked about, that, we've kind of had to, change some of our philosophy on, but we've also have time under our belt now because we've been doing that for a few years too, and it's worked very well.
Great. I think this moving more and more toward the patient not having to really participate that much in their postoperative care could really be beneficial. Any final parting words on this before we move to the end?
I might just go ahead, Cynthia. Yeah.
What I wanted to say is that drop installation is not intuitive to patients. They really struggle with it. So whatever we can do as surgeons to minimize the number of drops and the different drop regimens, the happier the patient will be.
Vance?
I agree with Julie too, that going where Neil has gone to totally dropless is our goal. We have been doing what we call our drop a day program for the last few years, and so we're down to 1 drop a day, but having a hard time letting go. So.
Well, thank you, panel. Excellent discussion. Great overall seminar. I'm going to turn it over to David, who's going to help us with the next step.
Great. Jared, I need my video. Yep, great. Well, thanks everybody for just an amazing session this morning. That was absolutely wonderful. And thanks to really all the faculty and the moderators. So this is your opportunity in the audience to now go to one of three, what we call Ask the Experts rooms. You'll see a little button link right above your screen, and you'll see the three topics there. You can actually exit and go into another room if you want. They're just sort of organized by topics. And like the rest of the program, everything is recorded and should appear on the 20 Happy website on Monday. So that allows you to review any of these talks or even to see what was happening in some of the other question and answer sessions. And then about a half an hour from now, if you use a separate link, you'll be able to do the non-CME symposium sponsored by Ocular Therapeutics, where they will be talking about a little more information about extended release steroid formulations. So thanks again for joining us. If you go to the website, you can also see the past corporate sponsored symposium, and we'll see you in the question and answer rooms.